My specific topic that I was asked to deliver was mild cognitive impairment and how I use the WAVi system for mild cognitive impairment. Compared to all the other presentations before me, as well as the ones in the morning, mine is very basic and just sort of, goes over some basic stuff. So I know a lot of you are very experienced and advanced, and I apologize in advance if, if it's all the basic stuff. But anyway, I know we're a little behind, so I'll get started. If we can go to the next slide. And so Dr. Yathraj was talking about positron emission tomography. In addition to neurology, I'm also board certified in nuclear medicine, and I actually read PET scans, both amyloid PET scans and fluorodeoxyglucose. So these are fluorodeoxyglucose scans of the brain, and really what it is it's radioactive sugar. The brain likes sugar, the brain takes up sugar. This is radioactive, so the positron gantry, the positron emission camera is picking up the radioactivity. And in Alzheimer's disease, you have these plaques and tangles, neurofibrillary tangles that Dr. Yathraj was talking about in specific parts of the brain, the temporal, the parietal, the posterior cingulate. And under Alzheimer's, you see that someone's taken a bite out of the parietal lobes, and so it shows decreased sugar activity. Mild cognitive impairment shows that we're heading in that direction. But I will say, when someone has mild cognitive impairment, it can be the beginning of a neurodegenerative dementia, but it might also be something fixable or reversible. And it's important to figure out what exactly is going on because they may not necessarily be heading to neurodegenerative disease. And we'll talk about how the WAVi fits into that paradigm. Next slide, please. So definitions of mild cognitive impairment, basically slight but noticeable and measurable decline in cognitive abilities, more memory or thinking problems than other people their age, stage between the expected decline in memory and thinking that happens with age and the more serious decline of dementia. So again, there's age-associated cognitive impairment. As we get older, we're more forgetful than we were when we were younger, but we can compensate for it, and we can use our smartphones and laptops and things like that to stay on task. If that's becoming a little more difficult, start thinking maybe mild cognitive impairment, maybe try to figure out what's going on, and certainly it becomes more disabling when it heads into neurodegenerative disease. Next slide, please. So mild cognitive impairment, 12 to 18% of people age 60 or older are living in mild cognitive impairment, so an important number. And we hear about all these statistics. As we live longer and longer, there's going to be more neurodegenerative disease, so an important topic to think about. Next slide, please. So other terminology used: brain fog, forgetfulness, memory loss, loss of cognition. Oh, sometimers, I like that one. So I have patients who come to me and they're like, doctor, I don't think I have Alzheimer's. I think I might have sometimers. So, good one to keep in mind. I won't go into all the details on this slide, signs of healthy aging versus mild cognitive impairment versus dementia. But the key points here would be, if you're sometimes forgetting or losing things, missing a monthly payment, that may just be healthy aging. But if you're starting to have difficulty coming up with the words, losing things more frequently, forgetting to go to events, start thinking mild cognitive impairment. And certainly when you're having a hard time managing your bills and finances and doing activities of daily living, or driving becomes a challenge, we might be heading into a neurodegenerative dementia. Next slide, please. So ICD codes used for mild cognitive impairment, and this slide is only here because, again, if you're using the WAVi system and you're, you want to use the appropriate codes. Next slide, please. So the hippocampus is important. When we're trying to commit something to memory, let's say someone gave me 3 words to remember. Those words have to go from my ears to my auditory cortex, from where they have to go through the part of the brain called the entorhinal cortex to the hippocampus. The hippocampus is where the memory is tagged. Then it goes back to the association auditory cortex. Now, 3 minutes later or 5 minutes later, you ask me to recount those words, I have to retrieve it from there. if there's a roadblock in the entorhinal cortex, the highway into the hippocampus, I might not remember those 3 words, or I might remember 1 out of the 3 words. And, you know, at least with neurodegenerative dementias like Alzheimer's, a lot of the pathology seems to start in this part of the temporal lobe, so important. We can go to the next slide. Common symptoms: forgetfulness, difficulty concentrating, trouble with complex tasks, losing train of thought, difficulty with spatial relationships. Next slide. And then these are just some other symptoms of cognitive impairment: missing appointments, overwhelmed by decision making or planning, forgetting words, conversations, difficulty understanding. So next slide. So risk factors and causes. So this is a pretty extensive list here, and that's where when in neurology, when we're evaluating someone who comes in with cognitive impairment, you do want to start with a good history, do an exam, and really think of all the categories of conditions. Dr. Yathraj mentioned some of these. So for example, a lot of times it ends up being a sleep disorder. The person may have undiagnosed, untreated sleep apnea, or just severe insomnia that might be causing their cognitive issues. The number 1 cause of pseudodementia is depression, so a lot of times it's a mood disorder. There's a myriad of inflammatory conditions, autoimmune conditions that could be contributing. We see vitamin deficiencies, sometimes we'll see toxicities, so just important to keep nutritional deficiencies, things to keep in mind. Next slide. And then in terms of normal aging, like we talked about, everybody experiences some cognitive impairment, but with mild cognitive impairment, it's becoming more significant. Next slide. So evaluation, just like with any other condition that you're evaluating, start with a good history and exam, lab testing, cognitive testing, and there's various levels of cognitive testing. Sometimes in the office, we'll do full scene mini mental status exam and Montreal cognitive assessment. These are not as detailed as a neuropsychometric testing with a neuropsychologist, but we can do it on an annual basis and keep an eye on the trajectory of the decline. So it is something that helps us monitor them over time, and there's various types of computerized exams: head CT, MRI, electroencephalogram, and obviously we're specifically talking about EEG with ERP, so I'll get more into that detail. Positron emission tomography, we talked about that, spinal tap, sleep study, and there's other specific tests that you can do, but this would be, you know, a good workup. So again, all the different conditions that potentially could be involved. The one thing I didn't talk about is medications. A lot of times I'll see patients with mild cognitive impairment. I'll look at their list of medications, and they're on benzos and narcotics and you know, sometimes dopamine antagonists and all these other medications. And again, I understand that sometimes you have to use medications that have side effects, but there's also a compounding effect where you've got multiple of these taken together, and that can be a problem. So simplifying their medication regimens is important. Next slide, please. So in terms of management strategies, manage underlying condition or causes, of course, remove offending medications, add symptomatic medications if needed, cognitive training and exercises, physical activity, heart healthy diet, social engagement, a lot of things that we've covered in other lectures today. Next slide, please. So this is kind of what we've already talked about. Next slide. Oh, and this is another code, 99483, for mild cognitive impairment. I won't go into detail. I think if the slides are available later, this is just a reference slide. Next, please. So these are just the key elements if you're using the CPT code 99483. And so, okay, so now I just kind of want to break down, again, for many of you this is probably super basic, but I just kind of want to dissect what the WAVi EEG is and how, at least in my practice, I utilize the data that I get from a WAVi EEG in helping me, not just with mild cognitive impairment, but all the other conditions that we use the system for. So routine EEGs have been around for over 100 years. We're looking at brainwave activity. It's a functional study of the brain's electrical activity, spatially oriented. determines normal activity, underactivity, or overactivity of the brain, helpful in determining global versus focal areas of dysfunction and determining seizure activity. Next slide. So this is important. This is the 10-20 system of putting the leads on the brain, because what you're trying to do is you're trying to ascertain electrical activity coming from the brain and pinning it down to the specific location in the brain that it's coming from. And so this is the paradigm that's used. If you notice, the odd numbers are on the left side of the brain and the even numbers are on the right side of the brain. And the F is for frontal, C is for central, T is for temporal, P is for parietal, and O is occipital. And those will always be placed in exactly the same way. So when you're looking either at a routine EEG or whether you're looking at a WAVi EEG, where you'll know when you see a certain activity which part of the brain that's coming from. That's what we mean when we say spatially oriented. Next slide, please. So this is a routine EEG. Those of us in the room who are neurologists were trained to look at these squiggly lines and make sense of these squiggly lines. The key things to glean from this is on the y-axis, you have the leads. And so here you've got FP1 to F2, F2 to T3, T3 to T5. And so there's a recording electrode and there's a reference electrode, and that just tells you which part of the brain that activity is coming from. And then on the x-axis, you have time. So the two thick yellow lines, that represents 1 second. So all the activity that happens within that time so for example, if you have 10 waveforms during 1 second, that is basically a 10 hertz activity, and then you would classify that as an alpha activity. And then you're also looking at the amplitudes of the waveforms. That basically tells you how much electrical activity is in there, in microvolts. And we can go on to the next slide. And then what is a WAVi EEG plus ERP P300 test? So basically you've got the electroencephalogram part, you've got the auditory evoked response potential. We're measuring the strength and speed of the brain's response to an auditory stimulus. So the key things here are when, I know most of you're here at the WAVi Summit, so I'm sure most of you are familiar with the WAVi system, but when you put those headphones on and you're basically getting these sounds that the ears are picking up and sending to the brain, and then every once in a while you get this high-pitched oddball sound, and the brain responds to the oddball sound. So the N100 basically just represents the negative potential that you get when the impulse goes into the brainstem. And then the P300 is when it goes up and is recorded by the EEG. And the voltage in microvolts and the speed with which the activity reaches the peak are important numbers to keep an eye on. Next slide. So this is just a normal WAVi EEG representation, and so some of the key things I look at when I look at this are physical reaction time, which is up there, and you have reference ranges, which are all, your normative database, which is age-matched, auditory P300 delay and voltage, theta-beta ratio, which is a strong marker of attention deficit, and F3, F4 power, which is basically for anxiety and depression. And then you've got the heat map. So the red in the center basically shows high voltage, which shows the P300 voltage, which is very beneficial, especially when showing it to patients as well. Next slide, please. And then this is just representing all the P300 voltages from the different locations on the EEG. Next slide. I had promised Jim I was going to breeze through these quickly because I have a lot of slides. Am I doing okay for time? Okay, 5 minutes. So this is just alpha frequency range, so you can just look at all the leads and see what the alpha frequency range is. Again, this is a normal WAVi EEG. Next slide. These are also some important things to look at. I'm not going to go into too much detail here, but the key things, because I've had a lot of colleagues who use the WAVi system, and they're like, okay, I can look at the key parameters, but how do you look at this stuff? How do you look at the what is absolute power and relative power, and amplitude, asymmetry, and coherence, and how do you incorporate that information? So the key things to remember here are the color map up top, or color key up top. 0 is median, and then you've got basically, if you think of a normal curve, you've got 1, 2, and 3 standard deviations. And so if you're at 0 and it's all color-coded, that means you're in a good range. If you're towards the red, that's very high, or high power, high amplitude, whatever you want to say, and blue is low. So, and then the other important things to look at here, absolute represents the amplitude or the power coming from specific leads, and you can see all those leads in there. Relative is each lead compared to the whole, because again, there's different skull thicknesses, things like that, so it kind of helps account for that. And then you've got the various, the bands, the theta band, the alpha band, and the beta band, and there's ranges up top. And again, this is a big topic. We can kind of go into it in more detail at some other point, I guess. But you want to look at, where the power, so for theta, for example, or for delta or beta, alpha or beta, which particular leads are out of range. So for example, on the earlier slide, I showed that theta-beta ratio is really helpful in determining attention deficit. Well, if the theta is really, really high and beta is really, really low, and specifically if theta is more than 3 times beta, that's very consistent with attention deficit, and this is where that data is coming from. Amplitude asymmetry is basically looking at the comparison between the two sides, and coherence is the crosstalk between the different leads. Next slide. Oh, and then this is another slide on coherence. Next slide. So I had a lot of cases on mild cognitive impairment. I knew I had a short period of time. I have 2 minutes left. So just wanted to show a couple of cases to kind of underscore how we use the data in these studies to help us, guide what we're doing. So this is a 24-year-old male with multifactorial mild cognitive impairment. But of all the different things that we looked at, one key thing was this gentleman had severe insomnia. When we did his WAVi EEG, his audio P300 voltage was 3.7, normal being 9 to 22, and his physical reaction time was 389, normal being 263 to 379. Those were the key abnormal parameters here. So we treated his sleep disorder, and we always recommend pharmacological and non-pharmacological interventions. We use both here. Next slide, please. So it didn't normalize it, but if you noticed after treatment, when we repeated the WAVi, his audio P300 voltage was better at 6.7, so closer to normal. His physical reaction time definitely improved. So again, if the question is, how do you incorporate the use of a WAVi EEG clinically, for your patients, this is one example of how you can kind of do an intervention and monitor response. Next slide, please. This was a 43-year-old male with mild cognitive impairment who on neuropsychometric testing was noted to have attention deficit. We did a WAVi EEG, and if you notice, his theta-beta ratio is 7.1, normal being 0.8 to 1.9, or reference ranges being in that range for his age group. So that is a very, very high number. The other significant abnormality was his physical reaction time was 481. So we can go to the next slide. For this gentleman, I put him on a stimulant, a methylphenidate, and I did have to titrate up the dose, and then eventually we repeated the WAVi. His theta-beta ratio normalized at 1.8. His physical reaction time significantly improved to 265. Again, all of this translated into a profound improvement. He's an attorney, has his own law firm, wasn't even able to work at his own firm. So you can make a difference in people's qualities of life, but the data is really helpful in guiding what you're doing for individuals. Thank you.